Hello everyone, my name is Yurong Jiao. I came from the second affiliated hospital of Zhejiang University School of Medicine, Department of Colorectal Surgery and Oncology. Today I'm talking about treatment strategy and surgical technique for pelvic lateral lymph nodes metastasis in rectal cancer. First, I want to introduce the division of pelvic lateral lymph nodes in rectal cancer. The pelvic lymph node was separated into 4 different zones, and each one has a number according to the classification system from Japanese colorectal surgeons. When we talk about lateral lymph node dissection, usually we are talking about the lymph nodes for number 283 and number 263. The incidence of lymph node metastasis rate is really low in number 273 and number 293 lymph nodes. The lateral lymph node metastasis rate of middle and low rectal cancer is really low, about 10 to 25% according to the literatures. As we can see in these 2 pictures, different part of lateral lymph node was separated in different colors. The treatment strategies for lateral pelvic lymph nodes metastasis are different in different countries. The Japanese guideline for colorectal cancer says lateral pelvic lymph node is considered as regional lymph nodes. TME operation combined with lateral pelvic lymph node dissection is the standard operation for low rectal cancer. The result of the clinical trial of ZJU-SAH showed that the lateral pelvic lymph node positive rate was 7% in middle and low rectal cancer patients. No difference in RFS at 7 years between 2 groups. The RFS benefit was observed in stage 3 patients. Preventive cleaning is recommended in middle and low position rectal cancer patients, while in the NCCN, ESMO, and the Chinese guideline for colorectal cancer, neoadjuvant chemoradiotherapy plus total mesorectal excision is the standard treatment for lateral pelvic lymph node with a low local recurrence rate. If lateral pelvic lymph node metastasis is highly suspected before operation, lateral pelvic lymph node should be considered even after the neoadjuvant chemoradiotherapy. Preventive cleaning is not recommended. Imaging evaluation of lateral lymph nodes is still difficult. The most commonly used and effective method is MRI, while CT scan and ultrasound can also be used as another methods. PET-CT is not used as a routine method for lateral pelvic lymph node patients. Despite various imaging methods, the accuracy of preoperative imaging in the diagnosis of lateral lymph nodes is still less than 80%. Here is some data from Dr. Ogawa from Japan, and it showed in the diagnosis of lateral lymph node metastasis, short diameter of 5 mm is an effective diagnostic criterion. The negative predictive value from this paper showed higher than 90% according to a short diameter of 5 mm as an effective diagnostic criterion. Another study showed that when the suspected lateral pelvic lymph nodes were treated with neoadjuvant chemoradiotherapy, the short diameters would shrink, and when the short diameter was less than 5 mm after neoadjuvant treatment, the metastasis rate was 0. So the conclusion is, if the short diameter of the lymph nodes is still greater than or equal to 5 mm after neoadjuvant treatment, option is recommended. If it's less than 5 mm, observational follow-up may be considered. Another research by Japanese Dr. Ogura showed that a lateral lymph node with a short axis of at least 7 mm resulted in a significantly higher risk of local recurrence compared to a lateral lymph node with a short axis of less than 7 mm in patients with clinical T3 or T4 stage rectal cancer up to 8 cm from the anal verge. Among patients with lateral lymph nodes of at least 7 mm in short diameter, The 5-year local recurrence was significantly lower in patients who received neoadjuvant treatment and total mesorectal excision and lateral lymph node dissection, compared with those only received neoadjuvant treatment and total mesorectal excision. As we can see from this slide, the short diameter of 7 mm can effectively distinguish the prognosis of patients with lateral lymph node metastasis. It also had been proved in Chinese patients according to this paper from West China Hospital. There is only one patient among total 65 patients had a recurrence with lateral lymph node, short diameter less than 7 mm. Okay, next, we will deepen our understanding of the lateral lymph nodes of rectal cancer through several actual cases. The patient was diagnosed with rectal cancer of clinical T3N2M0 stage on 2021, and the tumor distance to anal verge was only 3 centimeters, and the MRF is positive. Several enlarged lymph nodes were observed at the right pelvic area. The patient was enrolled in a clinical trial. Immunotherapy combined with long-term radiotherapy were performed. The MRI after radiotherapy showed that the primary tumor, lymph nodes in the mesorectum and the lateral lymph nodes were significantly reduced. And the doctor performed a total mesorectal excision in April 2022, but no lateral lymph node dissection for the right side pelvic. The pathological result showed YPT2N1M0. After the operation, patient went to the outpatient clinic every 3 or 6 months. As we can see from the CT scan, there's some lesion around the right side of pelvic, and it became more and more bigger according to the CT scan. And on June 2024, patient received an MRI test, showed that there is some recurrence in the lateral pelvic capacity. And also we do a biopsy, and the result showed metastasis poorly differentiated carcinoma. The second case is a young female patient with low rectal cancer and left lateral lymph node enlarged. Patient chose neoadjuvant chemotherapy. After 4 cycles of Capox, patient received a total mesorectal excision and left side lateral lymph node dissection. And the result showed there is no metastasis of all the 9 lymph nodes. The third case is a male patient with low rectal carcinoma, and he received also neoadjuvant chemotherapy. Before the operation, the right side lateral lymph node is very small, only 3.8 mm in diameter, but it turned out to be a metastasis lymph node. The fourth case is a male patient with low position of locally advanced rectal cancer with right side pelvic enlarged lymph nodes and treated with short course radiotherapy. After the treatment, the patient received the total mesorectal excision and also with the right side lateral lymph node dissection. And as we can see, the lymph node is not very big on the MRI, but the result also turned out to be positive lymph node by the right side. Here is another case of a small tumor in upper rectum, but with big lymph node metastasis to the external iliac artery. As we can see on the CT scan, that there are lots of enlarged lymph nodes around both sides of external iliac arteries. And we performed both sides of dissection for the number 293 lymph nodes. And the pathological result showed both sides of lymph node are metastasis 1. Next, we will talk about the structures in the lateral pelvic area. Here is a simple model for the anatomy and structures of the lateral pelvic. One pelvic wall, 2 triangles, the medial one and the lateral one, and 3 planes. The ureterial nerve plane, lateral wall plane, and also the vessel hypogastric nerve fascia. As we can see from these 2 pictures, showed the key structures within the medial triangle which contain blade, inferior vesical artery, ureter, hypogastric nerve, and the internal iliac artery. And this slide shows the detailed structures of the lateral triangle, which contains the obturator nerve, obturator vein, and the artery, and the piriformis, the Alcock tube, the internal pudendal artery, the internal obturator muscle, and the external iliac artery and vein. Here we present with a video of the left side lateral lymph node dissection. Step 1, we deal with the internal plane and start with the incision to the peritoneum along the ureter. And step 2, we expose the external plane and make the dissection of the number 283 lymph nodes. And be careful with the nerve and the vein. Don't make any bleeding there. And the third step is to dissect the number 263 lymph nodes, mostly around the internal iliac vessels. And in this area, you need to pay attention to the branches of the internal iliac artery and vein. If you are doing one side of the lateral pelvic lymph node dissection, you can dissect all the vessel branch of the internal iliac vessels. But when you do both sides of lymph node dissection, you need to save some branches to the blade. These videos above showed regular lateral lymph node dissection operations without radiotherapy or chemotherapy. Here is a difficult one who had a rectal cancer operation 2 years ago and found elevated CEA recently. The lymph node had a really good response to chemotherapy, and we decided to do the operation to remove the lymph nodes. In this operation, we are facing two difficult problems. The first one is about the space, because the rectum or the sigmoid colon is still there, and we are short of space to do the operation. And the second one is the lymph node itself, because it's like a metastasis lymph nodes, and we do the chemotherapy, and after the treatment, the lymph node is really hard, and it's very, very close to the external iliac vein, and we are paying great attention to prevent the vein and to not hurt it. The last case I want to show you is not actually a lymph node dissection operation, but it's some aneurysm of the internal iliac artery, which happened in the area of the lateral pelvic side. So at the beginning of the operation, we're still doing the same way like what we do on the lateral pelvic lymph node dissection operations, and along with the right fissure and to protect the ureter. And we found the aneurysm in the deep pelvic on the left side. And it's really big, and we can only see part of it. And then we go along with the surface of the aneurysm and pay attention to the branches of the arteries, which is, I think it's like the blood supply to the aneurysm. So after the dissection, one by one ligation for the vessels, and we can see the most part of the aneurysm. I think the key point for this kind of operation is not to cause any bleeding of the aneurysm, because the blood supply came from the internal iliac artery, and it's with a really high pressure. And if you got any bleeding there, you can see nothing in this area. But something bad just happened, even if we pay great attention to the blood supply of the aneurysm. At the 6 o'clock of the aneurysm, there is a big vessel. I think it's kind of branches of the internal iliac artery. And we want to use the stapler to seal with the artery, but we failed, and there's a severe bleeding happened. And because of the small space in the lateral side area and the high pressure of the aneurysm, it's very difficult to control the bleeding, and the blood keep coming out from the aneurysm. And at last, we give up, and we turn to open surgery to stop the bleeding and remove all the aneurysm. Fortunately, the patient recovered very good, and after 5 months of the operation, we do the CT scan, and the patient is fully recovered. There's no aneurysm anymore in the surgical area. So why the lateral pelvic lymph node dissection is so difficult for colorectal surgeons? I think there are some reasons. One is the narrow space in the pelvic, and the second one is hard to maintain high level of tension. And the third one is complicated anatomy of the lateral pelvic area, especially there's artery, vein, nerve, ureter, and bladder. And it's important to avoid bleeding, or you will lose details of the operation. And the increasing of the operation time and operative complications, especially for both side lateral pelvic lymph node, is extremely hard for doctors. And the patient who received new adjuvant treatment will make the operation even more difficult. So in conclusions, the lateral pelvic lymph node metastasis equals to N2 stage locally advanced rectal cancer by overall survival, and a new adjuvant treatment was recommended according to the data from clinical trial. And if the lateral lymph node is larger than 5 millimeters after new adjuvant treatment, you need to do the lateral lymph node dissection. The MDT is very important for this kind of cases, and I think surgeons should pay great attention to the lymph nodes in the lateral pelvic area. And at last, I would like to thank very much to my good friend David, and also I want to thank for the International Colorectal Surgery Training Academy of China. This program is great and bring lots of foreign doctors to China and work with us, and we can learn from each other. And thank you for your attention and your great patience. Thank you.